Imagine this. A bone doesn't just break, snap inside the body, it actually tears right through the skin, exposed to the world.
It sounds horrific, doesn't it?
It does, and it is. But, according to the source material we've been looking at for this deep dive, the visible injury, that shocking sight, isn't even the main threat.
That's right. The real danger, the sort of silent enemy that gets introduced, is infection.
Exactly. That broken skin barrier creates a direct pathway. It's like a superhighway for bacteria straight into the bone, into the tissue.
Precisely. It's
Yeah.
not just a complicated break anymore.
No, it becomes this immediate high-stakes battle. The risk of infection just skyrockets compared to a closed fracture where the skin's intact.
And the potential consequences are quite devastating, as the sources point out. Chronic infections, sepsis.
Even amputation, potentially. It really changes the game.
Welcome back to the Deep Dive. Today, we are taking a really close look at open fractures. You might know them as compound fractures.
That's the common term, yes. Where the bone actually pierces the skin, leaving everything inside frighteningly vulnerable. And the core problem, as our sources make absolutely clear, isn't just fixing the bone itself.
No, it's that profound exposure to contaminants.
Hmm.
Dirt, bacteria, you know it.
And the resulting massively increased risk of bacterial infection. So our mission today is to go beyond that surface level, to really extract the kernel insights from the sources we have.
Focusing specifically on urgent care, what needs to happen immediately.
And perhaps even more critically, the infection prevention strategies. What can be done to stop that devastating complication? Because managing these high-risk injuries effectively is paramount.
Indeed. It's a topic where understanding the details as laid out in these sources is absolutely vital. The stakes for the patient are just incredibly high.
Absolutely. And before we dive into all the granular detail, let's just set the stage quickly. A rapid-fire overview, pulling out the most critical points straight from the source material. So first question, beyond that visible injury, the drama of bone through skin, what is the single biggest threat highlighted in these sources?
Unquestionably, the sources identify the overwhelming risk of bacterial infection. That's the primary danger. It stems directly from that exposure, the sterile internal environment suddenly meeting the contaminated external world.
So it's the contamination that just shifts everything.
Got it.
Yeah.
Okay, next rapid one. The sources really stress the importance of speed. Time is critical in treatment. Is there a specific time frame mentioned for a key intervention, and why is that so critical?
Yes, they're very specific. Administering antibiotics within 3 hours of the injury, that window is critical.
3 hours, why so specific?
Well, because acting that quickly significantly reduces bacterial growth.
Right.
And crucially, it helps prevent the formation of what are called bacterial biofilms.
Biofilms.
These are protective layers bacteria build, making them much harder to kill once they're established. So hitting them early is key. 3 hours? That sounds incredibly urgent. Wow. Okay, and finally for the rapid fire. The sources talk about classifying these fractures. They particularly highlight type 3A, B, and C. How does knowing that specific classification actually impact treatment decisions or perhaps predict challenges based on what the source material tells us?
Well, the type 3 classification, according to these sources, signals really extensive soft tissue damage and high levels of contamination, so it directly guides treatment.
How so?
It influences the type, the spectrum of antibiotic coverage needed. You need broader cover, and it's also strongly associated with a higher likelihood of severe complications, things like delayed healing or the bone not joining up properly, non-union.
Right. So infection risk as the main enemy, a critical 3-hour window for antibiotics, and the classification system acting as an immediate guide. Okay, let's take a deep breath then and really unpack what the sources tell us in more detail. So in this first deep dive segment, let's start by really pinning down the definition of an open fracture based on the source material. And then let's get into why this infection risk is such a dominant, almost defining feature. What makes it so fundamentally different from a closed fracture where the skin isn't broken?
Certainly. The source material defines an open fracture, or as you said, commonly called a compound fracture, as a severe orthopedic injury. And what distinguishes it is that the break in the bone is accompanied by a wound in the overlying skin.
So the bone itself, or the force of the injury, creates that opening.
Exactly. Either the bone fragment pierces outwards, or the direct trauma creates the wound. But the result is the same. A direct channel is established, a connection between the normally sterile environment inside the body, the bone, the muscle, blood vessels, and the external world.
So that broken skin barrier is the absolute game changer.
Precisely. That direct breach means bone, and the surrounding soft tissues are immediately exposed to external contaminants. And you have to think about how these injuries often happen.
High energy events, usually.
Very often, yes. The sources mention things like vehicle accidents, motorbike crashes, or significant falls. Industrial and agricultural incidents are also highlighted as common causes.
And those environments are far from sterile.
Far from it. They're filled with dirt, debris, soil, grease, clothing fragments, and a whole host of bacteria.
And that exposure immediately drastically elevates the infection risk compared to a closed break.
Dramatically, yes. In a closed fracture, the intact skin is a remarkably effective barrier. It keeps bacteria out. In an open fracture, that barrier's gone, completely breached. So bacteria from the environment, maybe from the patient's own skin dragged inside, from clothing, from whatever caused the injury, they can directly contaminate the wound site and the exposed bone.
And the source stresses this direct contamination is the root cause of that huge leaked infection risk.
Yes, that's the fundamental difference, the loss of that protective barrier.
And the consequences of an infection taking hold in an open fracture are, as the sources detail, really severe, much more than just slowing down the healing of the bone itself. Can you walk us through some of those potential complications listed?
Yes, the source outlines a pretty grim spectrum of possibilities if infection sets in. It mentions chronic osteomyelitis that's a persistent, long-term infection of the bone itself. It can be incredibly difficult to eradicate completely.
Sounds nasty.
It is. Then there's cellulitis, which is infection spreading through the surrounding soft tissues, and potentially more systemic, life-threatening conditions like sepsis.
Sepsis, where the body's own response to infection goes into overdrive.
Exactly. It's a dysregulated response that can damage organs and become fatal. And these infections, almost invariably, lead to prolonged stays in hospital.
Right.
They often require multiple, complex surgical procedures to try and clean out the infection, remove dead tissue or bone. And in the most severe cases, as the sources highlight, tragically, it can result in the loss of the limb. Amputation becomes the only option.
So it really isn't just about the broken bone you're treating initially. You're primarily fighting to save the limb, potentially even the patient's life, from the consequences of infection.
That's absolutely right. The initial fracture management, while obviously important, often becomes secondary to controlling that contamination and preventing or treating established infection.
And the source also touches briefly on the wider impacts, beyond the physical.
It does. It notes the substantial emotional distress for patients facing these long, arduous, uncertain recoveries, and also the significant financial burdens placed on healthcare systems. Treating infected open fractures is complex, resource-intensive, and takes a long time.
It makes it crystal clear why preventing infection is the absolute #1 priority. And the source points out that even with modern medicine, infection rates in open fractures remain, and I quote, alarmingly high, especially in those high-grade cases from severe trauma.
It really does underscore the difficulty of the challenge. Even with everything we know and can do, preventing infection in these situations remains tough.
It highlights that simply setting the bone isn't enough. You have to actively, aggressively manage that initial contamination from minute one.
Precisely. Given the nature of these injuries, that contamination is almost inevitable. Managing it effectively is the key.
Okay, so with this incredibly high-stakes challenge defined, what does the source material present as the foundational pillars, the core strategies for managing these injuries specifically to combat this huge infection risk?
The sources clearly articulate a multifaceted approach. It has to be aggressive. They position three things as the absolute bedrock of management: timely administration of antibiotics, meticulous surgical intervention, and comprehensive wound care.
So not just one thing, but a combination.
Absolutely. It's presented as a coordinated strategy aimed at minimizing that infection risk and creating the best possible conditions for the body to heal. There's no single silver bullet here.
Let's zero in on the antibiotics first then, because the source really emphasizes the clock ticking. What does it actually say about the timing of giving antibiotics?
The source is very emphatic about the urgency. It cites evidence showing that administering prophylactic antibiotics, that means antibiotics given to prevent infection before it takes hold, rather than treat an existing one.
Right, preventative.
Within 3 hours of the injury occurring is crucial. That specific time frame is linked to significantly lowering the likelihood of bacterial growth taking off, and, very importantly, preventing the formation of those tough, resistant bacterial communities called biofilms.
Okay, we mentioned biofilms earlier. Why is hitting that 3-hour mark so vital in stopping them? What's happening with the bacteria in that window?
Well, the source explains it's essentially a race against time. Bacteria introduced into the wound start multiplying very rapidly. If you get the antibiotics in promptly, within that 3-hour window.
You hit them before they get established.
Exactly. You can kill or inhibit the bacteria before they build up large numbers. And critically, before they start producing that protective slime layer, that matrix that forms the biofilm.
Okay.
Once that biofilm structure is formed, bacteria embedded within it become hundreds, sometimes even thousands, of times more resistant to antibiotics, and also more resistant to the body's own immune cells.
Wow, that resistant.
Yes. So the source indicates that getting the antibiotics circulating in the tissues early helps prevent the bacteria from getting comfortable, if you will, and building these microscopic fortifications in the injured area.
That analogy of building fortifications really helps visualize it. It's about disrupting their ability to properly set up camp. So, timing is critical. What about which antibiotics? The source mentions specific recommendations, citing the American Academy of Orthopedic Surgeons, the AAOS.
Yes. The source details the AAOS recommendations for that initial prophylactic preventative antibiotic regimen. For most open fractures, the standard recommendation is a drug called cefazolin.
Okay.
Or, if the patient has a penicillin allergy, then clindamycin is the alternative. These are generally effective against the common types of bacteria, particularly gram-positive bacteria, that are often involved in skin contamination.
But you mentioned earlier that the more severe type 3 fractures might need something different.
Exactly right. The source specifies that for type 3 open fractures, remember, those are the ones with extensive soft tissue damage and high levels of contamination you need to broaden the coverage. You need to add protection against gram-negative bacteria as well.
Why the difference for type 3?
Because the nature of the injury, the extensive tissue damage, and the likely source of contamination, maybe soil, dirty water in an agricultural setting, for example, means there's a higher chance of gram-negative organisms being involved.
Right. Makes sense. So what drugs are used then?
This is where aminoglycosides come in, according to the source. Drugs like gentamicin or tobramycin are added to the initial cefazolin. This provides that necessary broader spectrum of activity.
Okay, so the classification, the type 3 designation, directly flags the need for this extra different antibiotic coverage. But the source also raises a cautionary note about these aminoglycosides, doesn't it?
It certainly does. It's careful to point out that while they might be necessary for adequate cover in these severe type 3 fractures, aminoglycosides carry significant potential side effects.
Such as?
Specifically, the source mentions nephrotoxicity, meaning potential damage to the kidneys, and ototoxicity, which can affect hearing and balance. And this damage can sometimes be irreversible.
So it's a tricky balancing act.
It is. It highlights that antibiotic selection isn't just about killing the bugs. It requires careful clinical judgment. You have to weigh the very real risk of a devastating infection against the potential toxicity of the drugs needed to prevent it. Especially considering the individual patient, do they already have kidney problems, for instance?
So, even within established guidelines, there's crucial clinical judgment required, tailored to the specific injury type and the patient's overall health.
Right, moving beyond antibiotics then. The second pillar you mentioned was surgical intervention and wound care. What does the source emphasize as being key here?
The source describes meticulous wound management as absolutely critical, and the core surgical procedure that's emphasized is prompt and thorough debridement.
Debridement, that's removing tissue, isn't it? What kind of tissue and why is doing it promptly so vital according to the source?
Yes, debridement, as described here, involves the surgical removal of all contaminated and non-viable tissue. That means dead or devitalized tissue muscle, fat, skin that doesn't have a blood supply anymore from the wound, along with any foreign material, bits of dirt, clothing, etc.
And why remove it? Because dead or damaged tissue, along with foreign debris, essentially acts as food for bacteria. It creates a perfect breeding ground, a nutrient-rich environment for them to multiply rapidly. Removing it eliminates a key factor that promotes bacterial growth and helps to significantly decrease the overall bacterial load in the wound.
So it cleans the slate, so to speak.
Precisely. And the source explicitly states that prompt debridement is crucial. Doing it early is vital for preventing infection from taking hold and for setting the stage for successful tissue healing later on.
It's like clearing the battlefield and removing the enemy's supply lines before the main fight begins. What about the actual cleaning of the wound itself? Does the source specify how that's done?
It does mention that open fractures must be thoroughly cleaned. This typically involves copious irrigation, washing out the wound with large volumes of sterile saline solution. This physically washes away visible contaminants, the dirt, grass, fragments, and also helps reduce the initial bacterial load before and during the debridement surgery.
And what about bone fragments? In severe breaks, the bone can shatter into multiple pieces. Are those small bits just removed?
The source addresses the handling of loose bone fragments specifically. It points out that any bone fragments that are devascularized, meaning they've lost their blood supply or are heavily contaminated, pose a significant risk. They can become a source of persistent infection, a sort of dead island where bacteria can hide.
So they need careful assessment.
Very careful handling and assessment by the surgeon, yes.
Hmm.
The implication from the source is that while grossly contaminated or clearly non-viable fragments might need to be removed, other fragments that are potentially viable or perhaps essential for rebuilding the bone structure might be preserved. But that decision itself carries an inherent infection risk that the surgical team has to weigh very carefully.
So even the bone fragments themselves become part of this infection risk calculation. Bringing this first segment together then, it's crystal clear this isn't just about fixing a broken bone in the usual sense. The moment that skin is broken, it triggers this urgent, complex response based on the source material we have.
Absolutely.
Getting specific antibiotics in fast within that 3-hour window, aggressively cleaning the wound, and surgically removing contaminated and dead tissue prompt debridement, and carefully managing even small bone fragments, all aimed squarely at preventing that potentially devastating infection.
Absolutely. The open nature of the injury fundamentally redefines the initial priorities. The primary focus shifts, as the source implies, from simply reducing and fixing the fracture to this immediate battle against contamination and potential infection. Surgical fixation of the bone often happens later, only after the initial debridement has been done and the soft tissues are stabilized.
Right, that makes sense. The priorities are completely reordered by that break in the skin. So we've covered the immediate battle plan, if you will, the urgent antibiotics, the crucial surgical debridement, the meticulous cleaning. But the source makes it quite clear that the fight isn't necessarily one size fits all. How does the type of injury itself, the classification we touched on, and even the patient themselves change the strategy or perhaps the prognosis according to these sources? Let's explore that now.
Right. As we briefly mentioned, the classification system for open fractures is a vital tool. The Gostillo-Anderson classification is commonly referenced in sources like these. And it's not just descriptive, it's highly predictive and really does guide clinical decision-making.
And you highlighted type 3 fractures earlier. What specifically about type 3, based on the source, makes them so different and so much more challenging?
The source clearly defines type 3 fractures by their severity in two key aspects: really extensive soft tissue damage and high levels of contamination. So unlike a type 1, which might just be a small puncture wound from the bone poking out.
Relatively clean, maybe?
Potentially, yes. Or a type 2, which has moderate soft tissue injury. Type 3 involves significant tissue loss, major muscle damage, perhaps stripping of the bone covering, or even damage compromising vital structures like nerves and blood vessels. And this is often combined with severe contamination. It's further broken down into subtypes. Type 3A, where despite the damage, adequate soft tissue coverage of the bone is still possible. Type IIB involves extensive soft tissue loss requiring complex reconstructive surgery, like muscle flaps, to cover the exposed bone. And type II is the most severe, involving an associated arterial injury that needs vascular repair to save the limb.
Okay, so the classification paints a very detailed picture of the scale of the soft tissue devastation and how dirty the wound likely is. How does knowing that classification specifically guide treatment or predict potential issues based on what the source says?
The source states unequivocally that this classification is crucial. Firstly, as we discussed, it directly dictates the type of antibiotic coverage needed. That requirement for adding gram-negative cover, often with aminoglycosides, for type 3 fractures stems directly from the expectation of higher levels and different types of contamination.
Right, the antibiotic choice links directly back.
Exactly. But perhaps more importantly, the source links these higher classifications, particularly type 3A, B, and C, to significantly worse outcomes. These fractures are associated with substantially increased rates of infection, even with optimal treatment. They also have higher rates of non-union.
That's when the bone fails to heal together properly.
Correct, and delayed healing in general. They often require longer treatment periods, potentially multiple surgical procedures over months or even years. The complication rate is just much higher.
It sounds like the classification acts almost like the surgeon's roadmap at the start. It tells them how tough the journey ahead is likely to be, and what specific tools or precautions they'll need, both in terms of antibiotics and the complexity of the surgical repair required later.
That's a very good way of putting it. It provides a critical indicator for prognosis and a framework for planning. Planning the necessary surgical reconstruction, the postoperative care, all based directly on that initial assessment of damage and contamination level.
Now, adding another layer of complexity here, the sources also point out that factors beyond the injury itself, specific characteristics of the individual patient, can significantly influence how things are managed and, crucially, the risk of infection. What patient-specific factors are highlighted in the material?
The source specifically identifies certain comorbidities, those are pre-existing health conditions, that can really complicate the management of open fractures and inherently increase the patient's risk of developing an infection. The primary ones mentioned are diabetes and any condition causing immunosuppression.
Okay, diabetes and immunosuppression, and anything else.
Yes, the source also includes smoking as another significant complicating factor.
Right. Let's break those down a bit. Why do conditions like diabetes or being immunosuppressed make these already difficult injuries even harder to manage and raise the infection risk?
Well, as the source implies, both diabetes and conditions requiring immunosuppression directly impair the body's natural ability to fight off infection and to heal effectively. In diabetes, you often have compromised blood circulation, particularly to the legs and feet where many open fractures occur.
So, less blood flow means.
Fewer immune cells and fewer antibiotics can actually reach the site of injury to combat the bacteria. Plus, high blood sugar levels, common in poorly controlled diabetes, can also directly impair the function of immune cells and create a more favorable environment for bacteria to grow. It's a double whammy, really.
I see. And immunosuppression. That seems more straightforwardly linked to infection risk.
It is. Whether it's due to medications, perhaps after an organ transplant, or for autoimmune diseases or conditions like HIV, immunosuppression weakens the body's defense mechanisms across the board. This makes the patient much less capable of clearing bacterial invaders on their own, increasing their susceptibility to infection from even relatively low levels of contamination.
So in both cases, the body's own internal defenses are weakened or less effective at reaching the battleground, if you will. And smoking. We all know it's generally bad for health, but how does the source suggest it specifically impacts open fracture healing and infection?
The source points to smoking having a significant negative impact on blood flow and tissue oxygenation. Nicotine is a vasoconstrictor. It narrows blood vessels.
Restricting blood supply again.
Exactly. This reduces the supply of oxygen and vital nutrients that are absolutely essential for wound healing and for delivering immune cells to fight infection. This impaired healing response and reduced local defenses makes smokers significantly more vulnerable to infection and also to other complications like delayed healing or that non-union we mentioned, where the bone just doesn't mend properly.
It really drives home the point that you're not just treating the broken bone and the dirty wound. You have to consider the entire patient's health profile. That dictates the best course of action and flags potential pitfalls.
Absolutely. The source's overarching point here is vital. These patient factors are not minor details. They necessitate tailoring the management approach. You can't just apply a standard protocol blindly. What works for a healthy young adult might be completely inadequate or need significant modification for an older patient with diabetes who also smokes. This tailored approach sounds crucial.
It really does.
It is. Effective management, as highlighted throughout the sources, requires integrating that assessment of the local injury severity, the classification, with a thorough understanding of the patient's systemic health and their specific risk factors.
Now, looking beyond the immediate management and patient factors, the sources also glance towards the horizon a bit. They mention some more recent advancements or innovative treatment modalities being explored for infection prevention. What does the material highlight in this area?
Yes, the source introduces the concept of ongoing research aiming to improve outcomes, and it specifically discusses bioelectric dressings as one example of a promising alternative approach.
Bioelectric dressings. That sounds quite different from antibiotics and surgery. How do they actually work, based on the source's description?
The source describes these dressings as generating low-level electric fields when they're applied to the wound. We're not talking about electrocution or anything dramatic. It's a very subtle electrical microcurrent.
Okay, a microcurrent, and what does that do?
According to the source, these electric fields appear to have a disruptive effect on bacterial activity. And specifically, they seem to interfere with the integrity of those bacterial biofilms we keep mentioning.
Disrupting biofilms. That sounds potentially very important given how resistant they are to antibiotics. How does the electricity actually achieve that?
The source indicates that the electric fields interfere with bacterial cell viability, essentially. They reduce the number of living bacterial cells. And perhaps more significantly, they seem to impair the bacteria's ability to adhere properly to tissues
Mm.
and to form those highly organized, tough, antibiotic-resistant biofilm colonies in the first place.
So it attacks them on multiple fronts, killing some, stopping others from sticking and building their defenses.
That seems to be the idea presented, and the source positions these dressings as offering promising alternatives, partly because they provide a potential method to help control bacterial contamination and infection risk that doesn't rely solely on traditional antibiotics.
Which is important given concerns about antibiotic resistance.
Exactly. In an era of increasing antibiotic resistance, exploring non-pharmacological approaches to infection control is becoming more and more important.
That's fascinating. It suggests the battle against infection in these complex open fractures isn't just confined to drugs or scalpels, but is actively exploring biophysical approaches too.
Yes, and it underscores the source's broader conclusion that research in managing open fractures is a dynamic field.
Yeah.
It continues to evolve, while timely antibiotics and meticulous surgery absolutely remain the cornerstone of current practice.
They're the foundation.
They are. But innovative approaches like these bioelectric dressings represent potential future tools that could enhance infection control strategies and hopefully improve patient outcomes further down the line.
So, pulling everything together from this segment, it's clear that effectively managing open fractures is an incredibly complex equation. You've got the severity and specific characteristics of the injury itself, captured by the classification system, that's layered with the individual patient's underlying health, their comorbidities, their lifestyle factors like smoking, and then you have this evolving landscape of treatment options, both the established pillars and these emerging innovations.
That's a very accurate summary.
The source really paints a picture of needing to integrate all these different pieces, the injury type, the patient-specific health profile, and the right mix of established and perhaps innovative treatments to achieve the best possible outcome for that individual.
Precisely. The comprehensive strategy that's advocated in the source material involves that prompt, aggressive initial management guided by the injury classification. Then, personalized care planning based on a thorough assessment of patient comorbidities and risks. And finally, a recognition that the field is actively exploring and developing new technologies, like these bioelectric dressings, to enhance our ability to prevent and treat these devastating infections. It's a continuous effort to improve upon existing protocols and try to bring down those alarmingly high infection rates.
It certainly highlights why orthopedic trauma surgery, dealing with these specific injuries, is such a demanding and specialized field. It requires such a deep understanding of both the mechanics of the break and the intricate biology of infection, healing, and patient factors.
Indeed. It's a constant interplay between surgical skill, infection control, and understanding the patient as a whole.
Okay, time for our lightning round. Rapid questions, rapid answers, drawing strictly from the source material we've dissected today. Ready? What's the critical time frame mentioned for administering those initial prophylactic antibiotics?
Within 3 hours of the injury.
For severe type 3 fractures, what specific type of additional antibiotic coverage needs to be added, according to the source?
Gram-negative coverage, typically using aminoglycosides.
What's the essential surgical step that involves removing contaminated and non-viable tissue from the wound?
Surgical debridement.
Name one specific patient factor mentioned in the source that complicates management and increases infection risk.
Diabetes. Or you could say immunosuppression or smoking.
And what innovative treatment modality is mentioned as using low-level electric fields to disrupt bacterial activity?
Bioelectric dressings.
Excellent. Clear, concise facts pulled directly from the source material. Very helpful. So let's just crystallize the absolute key takeaways from this deep dive into the source material on open fractures for you, our listener. What are the most critical points we've extracted today? First,
I think the fundamental point is that open fractures, by their very nature, carry an inherently high risk of bacterial infection. It's significantly elevated compared to closed fractures, simply because of that direct exposure of internal tissues to external contaminants.
and stemming directly from that high risk, urgent action is absolutely non-negotiable, particularly regarding the timing of one key intervention.
Exactly. The source really emphasized that getting those prophylactic antibiotics administered within that crucial 3-hour window from the time of injury is vital. It helps reduce bacterial growth and prevent those stubborn biofilms from forming.
The approach to managing these injuries isn't simple. It's definitely a complex, multi-pronged strategy, according to the source.
Yes, the source clearly outlines that effective management relies on a critical combination: timely and appropriate antibiotic therapy, prompt and meticulous surgical debridement to get rid of contaminated and dead tissue, and comprehensive wound care overall. All three are essential.
And that battle plan needs to be flexible, adapted based on the specific injury details and the individual patient.
Correct. The source highlights that the severity of the fracture, especially that type 3 classification and individual patient health factors like diabetes, immunosuppression, or smoking, profoundly influence the risk of complications and therefore necessitate carefully tailored care plans. One size does not fit all.
And finally, while these established protocols are absolutely key, the field isn't standing still. Research is actively pushing for new ways to fight this persistent infection risk.
That's right. The source acknowledges that research is ongoing and points towards promising, innovative approaches, like those bioelectric dressings we discussed, which could offer new tools for infection control in the future, potentially reducing our reliance on antibiotics alone.
It paints a powerful picture, doesn't it? This complex intersection of mechanics, biology, urgency, and personalized medicine that's required to properly tackle these severe injuries. This deep dive into the source material really makes it clear why preventing that potentially devastating infection is the absolute central challenge.
It really underscores that successful outcomes depend on a rapid, integrated, and highly informed response. It involves adapting established evidence-based protocols to the unique circumstances of each specific injury and each individual patient, all while keeping an eye on how the science continues to advance.
And as the sources suggest, that research is ongoing, constantly seeking better ways to prevent those stubbornly high infection rates. Given this continuous evolution and the exploration of completely different approaches like bioelectric fields, it really leaves you wondering, doesn't it? What might the next truly transformative breakthrough in preventing open fracture infections actually look like?
It's a fascinating question.
Could it be something entirely outside our current paradigms, perhaps leveraging, I don't know, genetics or even nanotechnology somehow to target bacteria more specifically or enhance tissue resilience in ways we haven't even properly imagined yet? Food for thought. If you found these insights drawn from our source material valuable today, please do consider rating and sharing this deep dive. Thank you for joining us for the deep dive.